All right, so thanks everyone for joining today. I'm really excited as we get started. I think we're going to start with Dr. Patty Sullivan. Before you all get started, I just want a quick 2-second intro about who you are, how you got involved in studying this kind of stuff and treating these patients, and then you can get right into your presentation. I'll pop in on each of yours as we go through. But Dr. Sullivan, on what you get started.
Sure. So I'm Patty Sullivan. I'm going to share my screen. I am one of the spinal kind of based neurosurgeons at Rhode Island Hospital. So I don't know how much background you want. I did my undergrad at Harvard. I did my med school at Hopkins. That's where I met our current chairman, and I did a research fellowship with him there with a lot of focus on spinal reconstruction and spinal oncology. A lot of the principles that apply to cranio-cervical instability really are very similar, I think, when I think about patients with metastases and other kind of oncologic disorders that cause instability. Then I did my residency at the University of Pennsylvania and came back to Brown for fellowship. I followed Zia here and then was recruited to the faculty. So as with Dr. Klinga and Dr. Svokos, my practice has really evolved to include trauma, degen, kind of degenerative pathologies, and then also patients with connective tissue disorders. So I think the three of us are really trying to work on ways that we can improve diagnostic criteria for these patients. I think we've come up with a really nice streamlined inpatient pathway and a pretty rigorous preoperative evaluation to kind of identify patients who have connective tissue disorders who benefit from surgical intervention. So a lot of what we do is really looking at the rostral end, or excuse me, the caudal end of the spinal cord, kind of thinking about tether cord. And this is sort of thinking about more of those rostral implications. So what's happening kind of at the cranio-cervical junction. So when we were brainstorming ideas about things we could talk about, um, craniocervical instability is a pretty common referral that we see in our practice. Because of my spinal reconstruction background, I do a lot of instrumentation. And so for patients facing craniocervical instability, questions about instrumentation, the pros and the cons are sort of something I see every day. And then when we think about how that impacts the treatment and evaluation of patients with Chiari, I think it becomes a really interesting and kind of very relevant clinical challenge. So my talk's pretty heavily clinical. I try to include a lot of pictures and keep the wording a little bit limited, but it goes into kind of what happens after the referral comes to me and sort of what we think about and all the angles that we're measuring. So feel free to stop me or raise your hand, although I think the Q&A will be at the end. So I don't have any relevant disclosures for this work. So thinking about craniocervical instability can refer to instability at the atlanto-occipital, or kind of the neck to head joint. When we think about the AO joint, we're looking at where the top of the cervical spine meets the bottom of the skull. So there's a occipital condyle that's shaped sort of like a half moon, and it rests upon the axis, which is the very top vertebra, so C1. So axis or C1, atlas or C1, and axis or C2. So that you'll hear kind of like a interchanging verbiage. When we think about this joint and this space, it's not only kind of bound by bony structures, but there's also a lot of ligaments that hold things in place. So we have to think about any diseases that affect ligamentous integrity or any traumas that can affect ligamentous integrity can kind of manifest for these patients as instability. And the question kind of becomes, how do we capture that instability? And for some patients, it's a pain predominant presentation. For some patients, it's neurologic dysfunction. So patients will present with, cord signal anomalies. And then when we think outside of the connective tissue population, one of the things that we worry about is patients who are elderly who have things like C1 or C2 fractures. So it's a very common sort of region of the body to succumb to fracture, especially as we get older and our bone changes. That if you have a head strike, especially a chin strike, that rapid extension maneuver is what's going to sort of compromise that C2 bone. And so disruption of the anterior atlanto-occipital membrane, the apical ligaments, the tectorial membrane, or any of sort of the membranes that are listed here can cause compromise of the stability at this joint. When you think about the top of the cervical spine and how it sits, why is it so important? The rotation of C1 on C2 is what gives you the opportunity to swivel your head. So in terms of functionality, if you're driving a car, being able to change lanes, aside from just the day-to-day sort of interactions with other people, it's important to be able to kind of visualize your surroundings. For patients who are wheelchair bound, maintenance of this movement is particularly relevant because in a patient who is kind of confined to a wheelchair, having the ability to kind of navigate in space is that much more important. So incorporating, obviously, I think we all know how important it is to see the whole patient when we evaluate someone clinically, but this joint in particular, we want to sort of maintain rotational stability and rotational axis when people are in a wheelchair or have any kind of compromised mobility. This is an illustration that really demonstrates how patients can have neurologic dysfunction with atlanto-axial instability, or specifically AAI, atlanto-axial instability. This is, and I'll go a little bit more into the nomenclature, but thinking about the relationship of C1 and C2, this is sort of the axial cervical spine. When there's over rotation or compromise of those ligamentous structures, the spinal cord can become impinged. So that little purple structure in the middle, it's funny actually that this picture, that's a mouse brain, but I think they thought that it looked like a spinal cord. So it's not the correct structure, but in principle, it's neural, I suppose. When you see the abnormal angulation of that C1, you're seeing that red kind of angry neural structure being compromised. And that's how patients can manifest with neurologic dysfunction in the setting of this type of dysfunction. The other thing is it's a very richly innervated region. So for patients who are sort of trying to describe migrainous type symptoms that are associated with this cranio-cervical instability, some patients will have neck pain that's sort of referred inferiorly. What I typically will have, the way that colloquially, or just kind of how a normal person would explain this, is it feels like hot searing pain, sort of if you put the palm of your hand at the base of your skull and up. That type of irritation of the nerve roots sort of in this area can be really painful for patients. And it's difficult to pinpoint if you also have sort of a crossover of a migraine syndrome, because sometimes the aggravation or the tension that comes from mild CCI or mild neck pain can really kind of lead to status migrainosus. And it's really frustrating for patients to sort of sort out which is the underlying problem. And so it's important when we're talking to patients when they say, I have neck pain or I have headaches, to really ask the question about what does that mean to you? Is this a headache that's more nerve pain type? Is this a tension type headache, or is this sort of in that family of migraine symptoms? The really great news is that we have phenomenal medications for migraines now. So for a lot of patients who have, and not to minimize it, but pain predominant CCI, there's a lot of medical treatment options that have been very promising, at least in my practice. So keeping this pain diagram in mind when you're evaluating a patient or talking to somebody, even just talking to another person about their neck pain, it's very helpful. The most severe form of craniocervical instability is what's called atlanto-axial dissociation. And I think this is what a lot of patients fear when we talk about CCI. I think when they come to my office, they're worried that their head is going to pop off, literally, because of instability of the joints. And so some of what I do is education with the patients to explain that we really only see this when a person has had a very devastating high impact injury. It's very rare that we see what we call AOD, or atlanto-occipital association. And the way that you measure it is looking at the tip of the dens to the basion, and we can go over some of these measurements a little bit later in the talk. But effectively, what you're seeing is there's a gap between the bones of the spine and the bones of the head. And when you see that gapping, it's very concerning for a neurological injury. It's rare that these patients don't also present with other injuries. Sometimes they can be other distracting injuries. A lot of times they'll be in spinal shock. And it's difficult, I think, for patients with connective tissue disorders who are also dealing with dysautonomia and POTS, because this really is very triggering for them, this fear that ultimately the ligamentous instability is going to lead to something as severe as this. In my practice, I've not seen it. And thankfully, the body has a couple of mechanisms to try to stabilize this joint. So this is an illustration of a patient that I'll be operating on soon. We're looking at a sagittal picture, so we're looking at someone from the side. We're looking at an MRI, and what we can see is that right there at the tip of C2, you can see kind of the base of the cerebellum, the base of the skull, right where the head articulates with the top of the neck. There's been a lot of bony remodeling. So the bones look like they're kind of what people would call bone spurs. So the body is trying to stabilize this joint at the atlanto-axial joint by depositing new bone. And the downside of that is when we see a lot of new bone formation, we can see what's called a pannus. And a pannus is what forms almost like if you've seen someone who has rheumatoid joints, like a really big, swollen, angry joint. The joint itself becomes painful. So that's a source of another type of pain. And then the other thing that we see is that that pannus slowly becomes larger and larger, much like somebody who has an untreated rheumatologic condition. The difference is that someone with a rheumatoid finger, the joint is growing outward into negative space. And unfortunately, in someone with AI or cranio-cervical instability, we're seeing that pannus grow backwards towards the spinal cord. And if you can imagine when someone's bending their head forward, it becomes a problem because the brainstem is draped and the spinal cord is draped right over that pannus. So, for patients who are dealing with ligamentous instability, whether that's from connective tissue dysfunction or other things, the body's first strategy is to try to deposit new bone formation. And so, when I'm evaluating a patient, I'm again talking to them about headaches, talking to them about neurologic dysfunction, provocative movements, especially with rotation. And then I'm looking on their imaging for signs that the body's already begun to try to stabilize that joint. This is another patient who had really severe AI that we operated on. This is a gentleman who was, in fact, wheelchair bound. So we had a lot of conversations about what cervical fixation would mean in terms of his mobility. I don't know if, again, how familiar everyone is with reading MRIs, but we're looking at that same sagittal or sideways view. And in this case, you can see that that pannus, the growth of new bone and other sort of, faux stabilizing forces, that growth is projecting backwards and it's causing direct compression of the spinal cord. And so this patient presented with profound weakness, which was really limiting him because he couldn't drive his power wheelchair anymore. And so that was something where we had to intervene. He ultimately regained function of his upper extremity. So even though it's severe and it looks like a very scary problem, when the surgery is done correctly and safely, and if the patient is able to sort of undergo the procedure, it has a very high success rate. This is sort of in contrast. So we're talking before about like the atlas and axis, that C1, C2, now thinking a little bit about dysfunction that's happening a little bit higher up at that occipital condyle to axis. And this is where we start to see more retroflexion, or sort of another term for it is more of a basilar invagination. So the top of that dens can sort of begin to migrate superiorly or posteriorly up into the cranial vault. And if you think about a Chiari, is where the Chiari, the cerebellar tonsils, are coming downward. When we're thinking about AI or CCI, we're thinking about the pannus sort of compromising the foramen magnum and compromising that space in a different way. It's just a different kind of cause of a very similar problem. Um, Unlike in Chiari, where it seems like there's quite a bit of spinal fluid dynamic problems, and you see syrinx formation, I haven't seen much syrinx formation from CCI, even in patients with degenerative trauma. And I think part of that is the slow progression, um, and the fact that just a lot of it tends to be associated with that hyper mobility, that dynamic movement. So this is another patient. Whenever I am evaluating a patient, we order a lot of imaging. An MRI, an upright MRI would be ideal. If that upright MRI can be performed in flexion-extension, that's great. If not, we typically will obtain CT imaging. A CT spine, this is again looking at someone from the side or that sagittal view. One of the things that I want to look at sort of throughout the patient's entire spinal canal is whether or not there's any evidence of lower spinal degenerative disease. And this patient does in fact have lower spinal degenerative pathology. So we want to think about, especially if pain is a driver or if myelopathy is a driver, we don't just want to focus on the cranio-cervical junction, we want to think about the whole spine. This patient has cervical spine evidence, like calcification or a pannus sort of at that C12 joint. And when we look at the joint space itself, we can see that there's already been some autofusion, where instead of seeing two distinct bones between C1 and C2, the patient's body has already begun to fuse that space. A lot of times what happens is that the body is trying, but it's unable to completely stabilize the space. And so what we see in this patient is a little bit of anterior flexion or anterior version of the dens. And this is all kind of subtle stuff, but this is what determines if a patient needs to have a fusion that goes up to the occiput or up to the base of the skull, or if you can just focus on C1-2. The other kind of really tricky thing about these surgeries is we have to look at the anatomy of the vertebral artery. So in patients who have POTS and EDS and some of the other syndromes that are associated with dizziness or dysautonomia, we do need to make sure that we rule out vascular causes of a patient's underlying sort of dizziness, especially with rotational movement. So the position and the health of that vertebral artery is going to dictate what's surgically feasible, so what we can actually do. When we think about what we can do surgically, there's some patients whose vertebral artery anatomy, that really important artery that supplies basically the whole posterior back circulation of the brain and cerebellum, we need to make sure that that's sitting in an anatomically favorable spot and that a patient has two functioning vertebral arteries or a patent, meaning a functioning intravertebral circulation. Because in surgery, we place a screw right here. And if a vertebral artery is kind of lying in that space, which I've seen, unfortunately, thankfully on the preoperative CTs, not intraoperatively, if that vertebral artery is injured, it's catastrophic. So the patient can have a really significant stroke. And the intervention, once you've injured the vertebral artery, is to sacrifice it. So we have to kind of go into any surgical plan thinking about what can happen worst case scenario. If a patient has other arteries that can kind of take up the load and do the work, then we can kind of quote them a different risk profile, a risk profile that's kind of more acceptable. Because the last thing we'd want to do is take a patient who's in pain, granted intractable pain, but give them a really profound neurological dysfunction. That's not what we want to do. Flexion extension cervical x-rays are typically also part of the evaluation. This is a little bit of a fine clinical point, but I've personally found that it's very hard to look at the cranio-cervical junction and the atlanto-occipital joint from flexion extension alone. For some patients with EDS, they've also, and other connective tissue disorders, they've expressed to me that they also feel like they weren't able to kind of give full range, whether that's a limitation of pain or a limitation of kind of what was available at the institution where they're obtaining the imaging. So there's a lot of variability in flexion extension x-rays and what we can interpret from them. There are some practitioners who use more advanced kind of fluoroscopy techniques to look at the capsular ligaments, which are the ligaments kind of at the joint spaces. As a practice, we don't have that modality here. I don't find them to really inform my clinical practice, but a lot of patients, if you're seeing them, will likely come with those x-rays as well that kind of go into kind of the integrity of those capsular ligaments. Usually from a fluoroscopy image, which is a higher level, more capable of dynamic imaging than this, kind of irrelevant to the discussion, but just didn't want to leave it out. So the next thing that I think about when someone has cranio-cervical instability or cranio-cervical dysfunction is basilar invagination. And that's when the tip of the dens involutes or kind of migrates superiorly relative to the basion. And this can be associated with just a cranial deformity that has been present since childhood, or it could be associated with slowly progressive degeneration, arthritis, things like that. These are all the lines that we use, but effectively, you don't want to see the tip of the dens more than 3 to 5 millimeters, kind of migrating superiorly into that foramen magnum. And it's effectively the bony opposite of a Chiari. In patients who have basilar invagination, it's a little bit more complicated of a problem because you can't just distract the spine away from that dens. You don't want to sort of put the spinal cord on stretch. So again, it's really thinking about how that basilar invagination is related to instability. In patients who have basilar invagination with a Chiari, it kind of makes things even more complicated because not a simple, but Chiari decompression, they're a very advanced surgical procedure. that might induce additional instability. So in this case, this is an illustration of how we measure the Chiari. We want to look to see less than 5 millimeters of inferior displacement or presence of a syrinx from the line from the basion to the epicyon. When you're looking sort of at an MRI, again, upright imaging versus supine imaging, I think the most important thing is if the patient is symptomatic, kind of determining if if the Chiari is clinically meaningful. And then I have sort of red arrows here illustrating the syrinx. So a syrinx is just that fluid-filled canal sort of in the center, a dilated central canal. And it creates a lot of issues for patients. So patients will present with myelopathy, kind of a cape-like distribution of numbness, burning. Patients will have difficulty ambulating, swallowing dysfunction. I've seen some of these syrinxes extend down into the thoracic spine, so patients will have radiating chest pain. Sometimes they'll present thinking that they're having a heart attack because they have unilateral kind of radicular chest pain. So there's many ways a Chiari can present, and we should always be mindful when looking at the cranio-cervical junction of thinking about that as well. Um, this is an illustration of a patient who has both basilar invagination, so upward migration of the dens, and a Chiari. And this is a patient in whom a Chiari decompression alone would not suffice. Removing the bone posteriorly would potentially destabilize and cause the dens to continue to migrate in that position, causing more severe neurologic dysfunction. And this is a case where a patient has basilar invagination with Chiari, and a Chiari decompression without stabilization would lead to cranio-cervical instability. And so this is kind of, they're all members of the same family. And I hope that I'm not, I'm trying to kind of build these things, but I know that it's very confusing. Um, that's why neurosurgery residency is 7 years. So another thing that we look at is the relationship of the tip of the dens to the clivus, which is that kind of bony triangle that you can see there. The clivo-axial angle, is something that we look at to see if, in the absence of basilar invagination, if the angle of the dens is sort of causing that neurologic compromise, that compression of the brainstem. It's more common in Chiari. Some reports quote that you'll see about 20 to 30% of patients with Chiari have some degree of abnormality within the clivo-axial angle. Not all of that means that those patients have to undergo surgical stabilization and fixation. I think it just changes the discussion of kind of the risks of doing more versus doing less. So if I see a patient who has a suspected CCI or AAI, so cranio-cervical instability or atlanto-axial instability, I usually start with cervical imaging, and I want to make sure that that includes C1 to C7 to look again for degenerative pathology. So it's a little bit more relevant depending on the patient's age. But an MRI is a good place to start. CTA imaging is specifically vascular imaging. So it's a CT angiogram looking at the blood vessels. So specifically that how the relationship of the vertebral artery changes my surgical planning. We have a program where we can do dynamic CT with flexion-extension. So unlike X-rays, where it's really hard to see in my hands, mild instability at the cranio-cervical junction, we see it much more clearly with dynamic CT. Upright cervical imaging is always helpful, understanding how the patient's head over their shoulders is functioning. And if there's any dynamic instability, even at we call it the subaxial cervical spine, so the parts of the cervical spine that are beyond C1, C2. The really good news is that for patients who have neck pain predominant without neurologic dysfunction, there's a lot of conservative treatment options that work very well. Botox for unilateral kind of muscle tension or muscle cramping. Botox can also be great for migrainous headaches. I usually ask patients about TMJ, so trying to kind of optimize if there's any kind of temporomandibular clenching that's leading to that sort of worsening head pain. Medial branch blocks and trigger point injections are usually performed by an anesthesia group or pain management group. And then targeted PT, we use a group that's familiar with connective tissue disorders and doesn't focus on range of motion, which is really tough for patients with EDS and connective tissue disorders, but rather is focused on kind of strength and stability and isometrics. And then, of course, a trial of medications. I think I'm running out of time here, but surgical fixation typically will look like this. This is a fusion at C1, C2 for treatment of AAI or atlanto-axial instability. And this is what posterior surgical fixation looks like for occipito-cervical fixation for patients who have cranio-cervical instability. And in our group, I think we're very conservative. Committing someone to this type of a surgical fixation is really a big deal. And I try to talk to patients about that before we kind of move forward with fixation. One of the biggest limitations of fusion is it will limit their ability to head turn when driving. It will, especially depending on how low the fixation is carried out. It may or may not impact their ability to sort of function quote unquote normally as if anyone is normal, but doing a full rotation with changing lanes, things like that. Doesn't typically mean that you are barred from driving in the future, but some people might not feel comfortable driving, and that can be very socially limiting. The other big concern is most people require some degree of tucking their chin to swallow. And this fixation limits your ability to chin tuck. So in patients who have swallowing dysfunction, a lot of our EDS patients have some degree of dysphagia or gastroparesis or other kind of GI issues. Losing the ability to chin tuck may not affect somebody in their 30s, but our hope is that these patients are going to continue to live meaningful, busy lives up into their 60s and 70s, and that's when we worry the dysphagia would present. And so it can be very limiting. This type of surgical fixation is really helpful to treat pain when the pain is caused by gross instability, when we see things like pannus formation. It is also very, very helpful to treat patients who have neurologic dysfunction. So, nerve symptoms or dizziness, or I lose strength in half of my body when I turn my head to the side. These are the types of patients who really benefit from this fixation. As a pain only for mild instability, I do not typically recommend this because just looking at the screws and rods, I think you can imagine it's a lot. It's painful. A lot of times patients can feel the plate sort of at the base of the occiput, depending on the thickness of the skin and the integrity of their tissue and their health. So very thin patients can have erosion at the site of the plate and skin issues. So we're very conservative, and I, in particular, am quite conservative about trying to exhaust all other options. The real exceptions are when we see that large rheumatoid pannus or that large degenerative pannus or when we have neurologic dysfunction. So I think I'm right at 30 minutes. This is the reason I do everything I do. This is my little guy. And I just have my email address there if anyone has any questions, but I guess we'll wait till the end. And thank you. I hope that worked.